Hello, everyone, and welcome to the Melanoma Research Foundation Ask the Experts series. My name is Kylie Lapira, CEO of the MRF, and we are so thrilled to have you join us today, especially during Melanoma Awareness Month. This is such a wonderful educational opportunity, and we're so excited to share and participate with you in today's webinar entitled, What Do I Do Next? A Roadmap for Care After an Early Melanoma Diagnosis. Our mission here at the MRF is to eradicate melanoma through funding innovative research, educating patients, caregivers, and the community, and advocating on behalf of their needs on a state and federal level. Education, as we all know, is so critical for patients. It enables them to make informed decisions about their care. We're very grateful to Castle Biosciences for their generous support of this webinar series and investment in the MRF's mission. Castle's mission is to improve health through innovative tests that guide patient care. Their tests provide actionable information addressing key questions in disease states such as cutaneous melanoma, squamous cell carcinoma, uveal melanoma, and Barrett's esophagus. A brief medical disclaimer before we get started. We encourage you to ask questions, and to do so, we want you to use the Q&A box throughout the session. We're going to wait until the very end after all of our panelists present, and then we're going to address questions. The information presented during today's session is for educational purposes, and any individual treatment questions should be directed to your healthcare provider. We encourage everyone to visit melanoma.org to learn more about the resources we have available for patients. Also, this session will be available as part of our on-demand library following today's session. And now, it is my pleasure to introduce Vicki Fish-Sidlow, VP of Marketing from Castle Biosciences, to introduce today's speakers. Vicki?
Great. Thank you, Kylie. Today, we are joined by three physicians who are leaders in dermatology and surgical oncology care, who will walk us through the process of diagnosing a melanoma, staging when a sentinel lymph node biopsy is needed, the importance of follow-up care, and long-term prevention after diagnosis. Our first speaker is Dr. Laura Ferris. Dr. Ferris is a professor of dermatology at the University of Pittsburgh. She directs the Pigmented Lesions Clinic and is the Director of Clinical Research for the Department of Dermatology and is a member of the UPMC Hillman Cancer Center Melanoma Program. Her melanoma interests include early detection of skin cancer through screening and the use of technology. Our next speaker is Dr. Genevieve Boland. Dr. Boland is an Associate Professor of Surgery at Harvard Medical School, Vice Chair of Research for the Department of Surgery, Section Head of Melanoma Sarcoma Surgery, and Surgical Director of the Termeer Center for Targeted Therapies at the Massachusetts General Hospital. Her primary clinical focus is on melanoma and cutaneous oncology. And our final speaker is Dr. Kelly Nelson. Dr. Nelson is an Associate Professor of Dermatology with the University of Texas MD Anderson Cancer Center, where she leads the Early Melanoma Detection Research Team. Her research seeks to reduce melanoma diagnostic disparities in areas of Texas with no dermatologists and combines geospatial imaging, educational theory approaches, and image annotation to support machine learning diagnosis. She also serves as the Associate Medical Director of the Melanoma and Skin Clinic at MD Anderson. Thanks to each of you for joining us today. And now I'll turn it over to Dr. Ferris.
Thanks so much. I'm going to go ahead and share my slides now. Okay, so I'm going to be talking about understanding your new melanoma diagnosis and what comes next. So some of the things that we're going to go over are, what does my pathology report mean? What are the next steps? And then we'll also talk later about what does the future hold. So starting with your pathology report. So oftentimes when you have a new melanoma diagnosis, your physician may share your pathology report, or really a lot of health systems make these available online. So I think it can be a little daunting sometimes to get this information. There's a lot packed in there. So I just wanted to go through sort of each section or things that you might encounter on a sample report here, which is what this is. So the first thing that you're going to look at that you may see is the melanoma subtype. So in this case, we have a superficial spreading melanoma. So this is the most common form of melanoma. It also has a very good prognosis. Other subtypes that you might run across would include nodular melanoma or acral melanoma, meaning that on the palms and soles, and those can be a little more aggressive. One of the most important things that we look at is what we call the Breslow thickness. So this is how deeply into the skin do the melanoma tumor cells go, or can they be detected? So what we're looking for is the lowest number. So thinner means better prognosis. So most melanomas that will be biopsied in the United States will fortunately actually be melanoma in situ, meaning that there was no tumor invasion that was seen. So we call this stage 0 melanoma. This has the best prognosis. It's really just sitting at that very top layer of skin, not invading down into the dermis or deeper part of the skin. If a melanoma is less than 1 millimeter, like the one in this example is 0.5 millimeter, that's called a thin melanoma, and that has still a good prognosis. If a melanoma is 1 to 4 millimeters, we would call that an intermediate thickness melanoma, and then we consider melanomas that are greater than 4 millimeters to be thicker melanomas. Sometimes you'll see Clark level. This is reported. This was used in an old staging system, but it is still often reported. And this really tells you what level of the skin the tumor invades to. So it's level 1 is just at the very top part of the dermis, and level 5 is the deepest that it's going down, sort of below the layer of the skin. Don't confuse this with disease stage. So you can have a Clark's level 3 melanoma that could still, depending where it is on the body, be still a relatively intermediate to thin melanoma. That doesn't mean you have stage 3 disease. And then ulceration is another component that's always measured. This indicates whether or not that tumor is growing quickly enough that you start to get a breakdown on the top layer of skin. So a melanoma with ulceration can have a little worse prognosis than a melanoma without ulceration. So you'll generally see this noted as present or absent. So this is just looking at why these are important and how we use them in staging. So we can see here, T1, when we look at T staging, that's how thick that melanoma is. So you can see T1 melanomas are 1 millimeter or thinner. So those are your thin melanomas. T2 and T3 melanomas are the intermediate thickness. And then a T4 is a melanoma that's thicker than 4 millimeters. That's your thicker melanoma, and you can see that the A and B staging here takes into account if that melanoma is ulcerated or has no ulceration. And so why this is important is if we look here at sort of the melanoma specific survival, we can see at the very top in that burgundy line is T1A. So the thinnest, this is just looking at invasive melanomas. The thinnest melanomas have really great outcomes. And then as we get into thicker and ulcerated melanomas, that we can see that melanoma specific survival probability goes down. And other things that we might see are mitotic rate. So that tells us how rapidly the melanoma cells are dividing. And so we see this as the number of dividing or mitotic cells per 1 square millimeter of tissue, and the pathologist can measure this. We'll see whether or not there are satellite metastases. So this means little nests or bits of cells that have broken off from that main tumor. And what we'll see generally is if these are present or absent. You may see a report on the presence of tumor infiltrating lymphocytes, but that's not always going to be present on every pathology report. And so what that's looking for are your white blood cells or the immune cells that can be seen actually attacking the tumor. So in general, you'll see if it's absent, non-brisk, or brisk. So the thought is that if you can see the immune cells attacking the tumor, that this might portend a better prognosis. And then regression. So this is whether or not you have an area of scar can be seen in the melanoma, where the melanoma used to be, but where it's been attacked and destroyed by the immune system. So this will be, regression will be noted as present or absent. This is just looking here at the number of mitoses. So we can see here and as related to melanoma survival. So we can see fewer mitoses means a less active tumor, and that has a better prognosis. And then we can see here the presence or absence of satellite lesions. There's really different types that we can see, but we can see that no satellite lesions, meaning none of that tumor has kind of microscopically broken off and gone into the surrounding tissue, has a better survival than if those are seen and found to be present. Finally, a couple other things. Lymphovascular invasion means, can you see tumor that's broken off and has actually gone into some of the small blood vessels or lymph ducts in the skin? And you'll see that as present or absent. Perineural invasion may be reported, and that's, can we see bits of tumor actually infiltrating or invading into the small nerves in the skin? And then whether or not the melanoma was seen in association with a mole, meaning it developed within a nevus or mole, or if it was not, meaning it just developed in normal skin. So again, not all pathology reports will show that. And then some will also say is that if this tumor is in a radial growth phase, meaning it's growing out or wider, or vertical growth phase, meaning it's growing down or deeper. So, you know, just a bit about just giving you the general idea of staging. Stage 0 or 1 melanoma means it's confined to the skin and thinner. Stage 2 can mean that melanoma has gone deeper into the skin or it's ulcerated. Stage 3, which Dr. Boland will talk about, is how we refer to melanoma that has moved and spread to the lymph nodes. And then stage 4 is melanoma that is spread beyond the lymph nodes and is in organs like the lung, liver, brain, for example. So what happens after you get your melanoma diagnosis? Almost all of the time, if possible, that tumor on the skin will be excised. We call that a wide local excision. And the margins, or the amount of normal appearing skin that's removed around that tumor, are chosen based on actually that Breslow thickness, or the amount that the melanoma has invaded. So if that is melanoma in situ, the latest guidelines would say that you have to take about 1/2 to 1 centimeter. So that's melanoma that hasn't invaded. It's at the top of the skin. If it's if it's invaded but only down to 1 millimeter or less, you would take 1 centimeter around that. And then if you have melanoma that's thicker than 1 millimeter, 1 to 2, you'll use 1 to 2 centimeter margins. And if it's thicker than 2 millimeters, it's generally recommended to do 2 centimeter margins. There are reasons why we may need to take less depending on where it is. For example, let's say that melanoma was on the face, and it was to take a 2 centimeter margin meant that you would go into the eyelid, for example. So there may be exceptions, and that's something to talk about with your doctor. There is another procedure that is called Mohs surgery, or really what we think of this really is a technique in which you want to look at all of the margins, the peripheral or the outside margins, as well as the deep margins. NCCN guidelines. So these are the guidelines that are sort of developed by a committee as being best practice in treating different cancers, and in this case, melanoma. Mohs surgery is something that's commonly used for other skin cancers like basal or squamous cell carcinoma. However, it's not recommended to be used sort of for all melanomas. The guidelines are that you can use it selectively for thin melanomas in anatomically constrained areas, like it's running into the eyelid, for example. Also for melanomas that are thin but maybe hard to see because their borders are not clearly defined, or they're in very sun damaged skin, and so these are times when you might want to have a different surgical approach. And then patients who, the guidelines also say that sometimes patients have a positive margin, so all of the edges of the tumor cannot be removed or can't be removed safely in the patient. So then it can be, you can consider using a cream called imiquimod, which helps to sort of stimulate an immune response to the tumor. Again, this is not something that we would typically do, but something in the guidelines and something in certain situations your doctor may discuss with you. So I'm going to be turning it over to Dr. Boland, who will talk about the procedure of sentinel node biopsy, but this is, she'll explain what that is. This is basically a surgical procedure to try to determine if the tumor has gone from the skin into the lymph nodes, so to determine if a patient has stage 3 or higher disease. And the guidelines say not everybody needs this. This is a procedure that's done if we think that the chance that melanoma has spread to the lymph nodes is greater than 5%, basically. So if it's under 5%, it's not recommended. If the risk is 5 to 10%, the guidelines would say talk about it with the patient and consider it. And if the chance is more than 10%, to talk about the pros and cons and offer it if it's appropriate for that patient. Dr. Boland's the expert in this, and she will talk about that. So at this point, I'm going to turn it over to Dr. Boland.
Great, thank you so much for that awesome introduction, and I will begin to share my screen. I think all of our presentations dovetail nicely, so thank you to Dr. Ferris. We get into presenter mode. So right, I'm going to pick up the baton. I think we'll highlight some of the similar topics and then kind of move into the nodal management a little bit more. These are just my disclosures, not relevant. So the good news, I think, for those of you thinking about this and on the call is that surgical management of early melanomas with a wide excision can be curative. I tell my patients, you have a local problem and I have a local solution, which is surgical removal. Certainly, you know, we can say nothing with certainty. We know that even in low risk patients, there are, you know, potential risks and probabilities, but in most cases, when identified early, we can curatively remove melanoma, which I think is a great take home. As alluded to, we have guidelines relating to the margins and the width of excision. I tend to do the same depth of excision for all melanomas, which is to the next anatomic layer, generally the fascia, the lining of the muscle, if that's where you are in the body. And, you know, this is just to show, and we don't need to get into the weeds of the trials, that these are the seminal trials that were done to establish the margins of excision. We want to do the most that we can for you oncologically, for patients oncologically, to a good cancer operation, but spare morbidity from doing too much. And the guidelines have arisen from this, although there are certain areas where the direct head-to-head comparison hasn't really been made. And so again, as Dr. Ferris very nicely laid out, these thin, low-risk melanomas generally are the ones that we treat with curative intent with a wide excision alone. The margins of excision, as we mentioned, for these, a 1 centimeter margin is generally adequate. And often, aside from sensitive areas like the face, the foot, the hand, and other areas, can be closed without major morbidity. This group in the middle are the groups where the trials I just showed you didn't do necessarily a head-to-head comparison. So we have some leeway in this 1 to 2 millimeter melanoma category of using a 1 or a 2 centimeter margin. Most of us would generally favor a wider margin if no anatomic constraints exist. So there are places like the face or near the eyelid that we've alluded to where it would be favorable to use a more narrow margin if appropriate. And then the intermediate and the thick melanomas are all excised with a 2 centimeter margin. So these are radial margins from the biopsy site in all directions. And generally we have to elongate the incision in order to close it, but these are the oncologic or the cancer driven margins. And historic data, so this is from some of the earlier trials that were read out more recently, suggests that a wider margin is associated with lower melanoma specific survival in this follow-up data from studies that were done many years ago. But I think the caveat to that is they really probably don't represent the therapeutic landscape of what we have now, meaning early melanoma patients who had disease severe enough to recur and die of their disease that may be treated differently now than they were in the era in which this trial was run. And there are ongoing trials in the melanoma world to address the question of how wide of a margin do we need to go. Again, in many anatomic locations, this is not a major thing. It's a slightly larger incision for the patient, but there are certainly anatomic sites where a more narrow margin would be favorable for the patient if oncologically reasonable. So this is a trial that's ongoing to try to address that question. And then, the curative intent surgery is a wide local excision. That's what I tell my patients. But it is important to note that patients can have microscopic disease. So a disease that wouldn't be palpable on a physical exam, no lumps and bumps you could feel in the lymph nodes, might not even be seen on a scan, but might have a few cells that have left, where they started, the melanoma, and gone to the regional lymph nodes. And I like this photo because it demonstrates that in different parts of the body, the lymphatic spread and lymphatic channels are different. And so on the torso, we don't necessarily know which lymph node basin the patient is going to map to, but we can do this procedure called a sentinel lymph node biopsy. And what happens is the radiologist or the surgeon injects a dye, and then we also use a blue dye. So sometimes we use 2 different dyes, but you can see here nicely in this diagram that the dye is injected right in 4 quadrants next to the melanoma, and it just follows the channels that the cells would follow were they to leave the melanoma and go to the regional basin. So I tell my patients, it's not cancer specific, the dye. It's not following a melanoma cell and binding to it. It's just a roadmap of where the cells might have gone if they left the primary tumor and went somewhere else. And this was the seminal study about melanoma, and I don't want to get into the weeds of the data, but just to say there was a big study looking at the use of sentinel node biopsy, yes or no, in appropriate patients. And the take-home message is that the procedure itself was not curative. It didn't improve survival just by doing the sentinel lymph node. But what was very clear is that the information gathered from the sentinel node biopsy procedure, meaning if you had disease in the lymph node versus not, that information was very important and correlated with your risk of disease recurrence. And so the prognostic value or the information gathering value of the lymph node sampling is really why we do it. So the curative intent surgery is the wide local excision. The information gathered in appropriate patients by the sentinel node biopsy helps us have a more informed conversation with the patient to say, should you have more surveillance? Should we monitor you more closely? Should you go on to more treatments? And so having that risk stratification information is very valuable. And that's the purpose of the sentinel node. And as was shown earlier with the NCCN, ASCO, the American Society of Clinical Oncology, and the SSO, which I'm a part of, the Society of Surgical Oncology, have both have very similar recommendations to the NCCN. And as was mentioned, sentinel biopsy is recommended for intermediate thickness melanoma. Again, I will put sort of the asterisks here in the appropriate candidates, and we can talk a little bit about that maybe in the discussion to follow. And then can be recommended for thick melanomas. Most of the time, the reason there was not much enthusiasm for this information in patients with the thicker or the higher risk melanoma is that they were going to be monitored closely and the risk of recurrence anywhere in the body was higher. And so the question was, what's the value of information about regional spread, and could be considered for thin melanomas that are in the slightly higher risk group. And again, as mentioned, these cutoffs were based upon the probabilities of finding disease, and with a threshold of about 5% to start the conversation. But I will say, as somebody who, I'll go back one slide, as somebody who counsels patients about these decisions every day, there are a lot of patient-specific variables that go into this conversation. Both, the safety of the patient to undergo general anesthesia, which is required for the sentinel node biopsy procedure. So the risk benefit of information versus surgical risk, patient preference. So it is quite a nuanced conversation. It's not a, slam dunk that, one thing leads to the other. And then I think as we are representing in this panel, the treatment decisions in melanoma patients are really multidisciplinary. And I think the more we know and the more therapeutic options we have, the more a group conversation, even in earlier management, is becoming more and more important. And so I'm very grateful of the team that I work with, and I am eager to continue this dialogue. So I'm going to pass this on to my colleague for the next section. Thank you all so much.
Hi, everyone. I'm Kelly Nelson. I'm an associate professor of dermatology at MD Anderson Cancer Center. And I'm so sorry I can't be with you in real time this evening, but I am glad to be able to join you in any way. I'm going to talk a little bit about how you can take good care of yourself after a melanoma diagnosis. And I don't have any disclosures. And I'm going to talk a little bit about how I've seen things work well for patients in terms of their physical health, their mental health, and then taking good care of their families. So the first step is making sure that you've had a really good skin examination by a board certified dermatologist. There are all sorts of different ways that people get diagnosed with melanoma, and many people are diagnosed with melanoma through a board certified dermatologist. But there are also a lot of amazing primary care physicians, advanced practice providers, and surgeons who help patients find their melanoma and receive their diagnosis. Dermatologists, though, have specific technology available to them to really take good care of you moving forward. And that technology includes the use of dermoscopy. A dermatoscope is a handheld magnifying lens that uses polarized light and different degrees of magnification to get a much closer look at things on your skin. And with appropriate training, dermatologists who use dermoscopy regularly can remove far fewer normal moles that never need to be taken off of you. And they can also find subsequent melanomas at earlier stages. I consider myself to be a ninja master dermoscopist. It's one of my talents, but to get really good at it, I had to take pictures of everything that I biopsied for a long time. I still do that, and it still helps me learn. So finding a board certified dermatologist who uses dermoscopy and in a world of puppies and rainbows also takes pictures of what they remove from your body will help make sure that your doctor continues to learn about you and your moles, and hopefully you never make another melanoma, but if you do, it's certainly helpful to have a picture of that melanoma to learn from. Total body photography is another enormously helpful technology in taking care of our patients who've had melanoma. Normal moles stay the same. They don't grow and change. Melanoma, by definition, grows and changes over time. So having a set of baseline pictures that we can refer back to know if things are really changing or not is enormously helpful. The quality and sophistication of these photographs can vary widely, but even just a baseline set of pictures with your smartphone is better than nothing at all. Because when you're with your skin every day, it's hard to appreciate what's changing from day to day. It's just like with your kids, you know that they're growing, but from one day to the next, you can't really appreciate that change. But having those pictures can really be helpful. And then depending on where you are and the resources that are available to you, reflectance confocal microscopy can be helpful in specific circumstances, but in the hands of a physician who's experienced using it. And it's not broadly available because of the cost and the just general learning curve associated with the technology. Outside of that, being aware of your own skin, being aware of your lymph nodes, these are important things as well. Different people have different desires to be aware of their skin. Some people don't care one bit. If you have a loved one who falls into that camp, helping to be aware of their skin can be enormously helpful in trying to find something that's changing sooner rather than later. Trying to be safe with your sun and UV exposure practices. I see a whole spectrum of this with my patients. I have some patients who love playing tennis and they really don't want to have sunscreen running down into their eyes even after they've been diagnosed with a melanoma. And I have other people who go to the other end where they really aren't going outside in the daylight anymore. And I think there's a happy medium in there of wearing some protective clothing, wearing sunscreen, but shifting the hours of your outside activities to be earlier in the day and later in the day. My family and I, we still go to the beach. We take a big umbrella. We wear sun protective clothing. We use high SPF sunscreen, but we still go to the beach because it's something that we enjoy. So just trying to sort of recognize what you can control and what you can't and still live a happy life. These are good things to have in your have in the back of your mind. And that tips over into the mental piece. I think that mental health following a melanoma diagnosis is something that we don't talk about enough. And I certainly see the full gamut in the patients I've taken care of. I see some patients who really brush it off and say, I'm going to be fine. I'm not going to talk about that anymore. And then I have other patients who feel like every mole on their body is a ticking time bomb. And the recipe for that scenario seems to be a young parent who went to a doctor and said, I don't like how this looks. And the doctor said, that's fine. And they insisted and said, no, I want it off. And it turns out to be a very early melanoma. And then that patient feels that they are the only one who can find their melanoma. And what that translates into for some people is that they now become obsessive with checking their moles. And they don't usually volunteer this, but when I sit down and talk to them, they will say that they're on melanoma forums at all hours of the night. They are checking their skin, doing full skin checks multiple times a day. They can't do the things that they normally want to do in their life because of the amount of worry that has subsumed their psyche because of this past experience. And a lot of it seems to happen mainly in young parents because the thoughts are unbearable. What if I miss something and I die and I'm not there with my children as they grow up? I would say I've taken care of about 30 to 40 patients who've experienced this scenario. And what I found to be helpful is we get the total body photographs that we talked about before. When I see the patients, I compare mole to their baseline pictures and say, that's not changing, that's not changing. Those are okay. If there's anything that they're losing sleep over, I will take it off, absolutely. But I photograph it first. So if it is a very subtle melanoma, I can learn from it. And I tell patients to come and see me every 6 weeks and let that burden rest on my shoulders as their doctor and take it off of their shoulders, because that's my job. And over time, 99% of my patients have been able to slowly graduate out to what is considered a standard follow-up interval of 3 to 6 months, depending on where they are and how their melanoma was diagnosed. So know if you feel like that is happening to you, that there's a way out of that and that there's a path for you to be in a good place again with your thoughts. But you need to let your doctor help you. I'm attuned to it because I've asked the questions and I recognize the subtle signs when that's happening for my patients, but not all doctors may know that. And so just asking for help if you need it is really important. Be aware of the worry for your diagnosis spilling over into other areas of your life. Because if you're not able to get the sleep that you need, if you're not able to walk your children to school, those are signs that you may need more help than what you can do on your own. And there's no shame in that, because there are practical things that you can do to take good care of yourself. You can control what you can, which is within the scope of reason. It is still okay for you to go outside to do the things that you need to do. But it's also good that you let your loved ones in your community help you. And that means your family, but also your church family, other people who are close friends to you, to share that part of yourself with them so they can help you. And again, to just share that with your doctor, because otherwise your doctor may never realize that you're struggling. And that there are really amazing psychologists and psychiatrists who are there to help you if you need it. And there's no shame in asking for that help. I want to touch very briefly on something that could be a whole hour-long symposium, but just to talk briefly about melanoma and genetics. A lot of my patients want to know, what does this mean for my children? What does this mean for the rest of my family? Should they start getting skin checks now at age 6? These are all things that talk about the risk that's passed from one generation to the next. And when we talk about melanoma, especially advanced therapy for melanoma, we sometimes talk about mutations, BRAF mutations and things like this. And I think it's good to know that there are different mutations when we're talking about melanoma in the specific context. So germline mutations are mutations that are passed from across generations that are inherited from the parent to the child. There are different mutations that arise within a melanoma itself. And so what I'm talking about is that risk from one family member to the next across generations, and that's considered germline mutations. When we start thinking about there being inherited risk from one generation to the next, one of the things that I think about is the rule of threes, which is what's used in the United States to assess risk for an inherited melanoma genetic issue. And we think about that when there are 3 or more immediate family members on the same side of the family who've had invasive melanoma. Melanomas in situ don't count. Or one person who's had 3 melanomas. Now, we also count pancreatic cancer when we're doing this rule of threes. So if you've had invasive melanoma and you have 2 siblings who've had pancreatic cancer, that counts for the rule of threes to suggest that you may want to talk to a genetic counselor. And there can also be, if there are other types of cancer running on the same side of the family as melanoma, that's something that you want to make sure your doctor knows about. And the discussion with a genetic counselor is enormously important. There are a lot of blood tests that can be ordered very easily now, but the genetic counselors are really the most skilled professional to help you understand your risk and what it means to your family. And depending on what may be identified, it could change how we take care of you or take care of your family members. So just to have a little bit of awareness about this, and I know this could be a whole hour-long talk, but it's just something to make sure that your doctor is aware of your family cancer history. So just to put it all together really quickly, to take good care of your physical self. Make sure you find a dermatologist who uses dermoscopy, who you feel like you can talk to, and who you can trust. Check in with your mental self. Get a sense of whether those worries are spilling over into other areas of your life, or if you feel like you just need to, that you're on a good path forward and you know how to control what you can. Make sure you know your family's cancer history. Something that, depending on your generation, people may not want to talk about, but it's something that can really help your doctor take very good care of you. And that is the end of my talk, and I really appreciate being able to spend some time with you all this evening.
Wonderful. Thank you so much, Dr. Ferris, Dr. Bolin, and Dr. Nelson. Again, Dr. Nelson isn't able to join us live for Q&A, but we're going to start asking some questions. For those of you who have put questions in the Q&A box, thank you so much. And please, again, if you have questions, now is your chance. Just use that Q&A box at the bottom of your screen, and we will get to as many as we can. If we run out of time, we have about 20 minutes left. You can email education@melanoma.org, and we will address your questions offline if we do run out of time. So I'm going to start with the first question, and this is probably more to you, Dr. Ferris. One of our participants asked, at what point should one be referred to a melanoma oncologist, so a specialist, or perhaps to Dr. Bolin, a melanoma surgeon, if the primary doctor and not the dermatologist does the initial biopsy? Should you receive a referral?
So, you know, my feeling is once you have a melanoma diagnosis, if it's an option, it's good to have a melanoma team. And that really holds true more so for patients who have invasive melanoma, or, you know, and particularly patients who have stage 2 or higher melanoma. So one, you need to have, there are therapy options that are sort of beyond what we talked about today that actually start for patients now even with stage 2 melanoma. So one, you want to know all your options. I am a big believer that our primary care colleagues are very helpful in helping us to identify melanoma, maybe in patients who don't see dermatologists, or who would have not known that they had it, or they're frankly who don't have access to dermatologists. However, I think once you're diagnosed, as Dr. Nelson said, it's good to see a dermatologist for that full skin check. And then to talk about, you know, do I need to see somebody like Dr. Boland? Do I need my lymph nodes evaluated? Should I be seeing medical oncology? You know, there are lots of patients who have melanoma in situ. I manage them on my own, or maybe they've had a 0.2 millimeter melanoma. I can manage them on my own. But I think you want somebody who really knows the disease and knows when it's time to involve the next member of the team.
Anything to add, Dr. Boland?
No, I agree. I concur. I think the patients get a lot out of the educational components. I think a lot of people can do the procedures, but I think understanding and giving them context is really important. And I think many people with a new diagnosis of melanoma or something in the family have a lot of questions. And so I think certainly, you know, oftentimes I can have conversations with patients and not even necessarily do their surgery, but I would agree that connecting to the right team and setting up not just the procedure, but the surveillance. You know, my dermatology colleagues do an amazing job. I see a ton of melanoma patients and I don't manage them for skin checks. I send them back to my dermatology colleagues because of all of the reasons that have been pretty clearly delineated. So I think setting them on that pathway sets the patient up not just for a good outcome from their procedure, but really on a longer term trajectory. That's very helpful.
And I would just add to, you know, somebody like Dr. Boland, who does a ton of sentinel lymph node biopsies, is very good and very accurate at this procedure. So, you know, it has been shown that the number of procedures you've done actually is correlated with the accuracy of your results. So if you're going to have this procedure done, you want to get the right answer. If it's negative, you want to know that's truly because there wasn't melanoma in that draining basin, and if it's positive, you don't want to miss it. So not all surgeons have the level of experience that somebody who's a trained surgical oncologist, and particularly somebody who specializes in this procedure like Dr. Boland would have.
Agree. And I think also, as I said, there's patient-specific variables. We always have to weigh the risk-benefit. So I would agree, these conversations are nuanced. There are many people capable of components of it, but I think the multidisciplinary care and the care of people who do this a lot is in the patient's best interests.
So a follow-up question to that, Dr. Boland, then, is there ever a reason why, again, you would steer a patient away from a sentinel lymph node biopsy if they have an intermediate thick melanoma?
Yeah, I think it's a conversation. I mean, I think that I tried to drill home, and this is the tone of the conversation I have with the patients, that it's a prognostic procedure. It's one that's very powerful, meaning the information we gain from the sentinel node biopsy procedure is incredibly valuable and helps us have these very complicated conversations. But there are some patients in whom that information may not outweigh the risk of surgery. And while the surgeries are considered minor, they're outpatient, they are done under general anesthesia. And for people who have complex medical problems, or for people who have other ongoing medical issues, we have to weigh the value of that information with the procedural risks, which are minor, but there are a subset of patients who have, you know, would be appropriate for the sentinel node biopsy procedure, who for a variety of reasons, medically or otherwise, may not be the best candidate. And then it also is a conversation. I have patients who just do not want to have extra surgery when it's for information gathering. Even if we think that information is important, if it's not a curative procedure, they don't want the extra surgery, and I can also respect that. But then we have to come up, again, this is part of being seen by an expert team, of a contingency plan to monitor them because they're kind of falling out of maybe the standard recommended guidelines.
Thank you so much. So let's talk about timing, and then I'm going to jump back to the questions that are popping up in Q&A. And again, if people could just put the questions in the Q&A box. If you have comments, please feel free to put them into the chat. You know, we have a patient forum through the MRF, melanoma.org, a patient forum, peer-to-peer. And one of the things that has come up quite a bit is timing. So one person said they had a mole that was biopsied, it came back positive, but they have to wait weeks to get their excision and potentially a sentinel node biopsy. They're not sure, but they're very worried that the melanoma is going to spread. How long is too long to wait between biopsy and surgery? And that's for you, Dr. Boland.
Yeah, I think that's in my wheelhouse. This is a very common conversation that we have. And I think, you know, obviously COVID changed our practice patterns for a little bit. And thankfully, we're back to what we would normally have done. I tell my patients weeks, not months. And there's really important steps sometimes that we need to go through. It's not just scheduling or OR access. Sometimes we do staging prior to surgery in higher risk patients. And I often tell them many times, not always, the biopsy takes out the majority, the bulk of the tumor. We often see just a biopsy site rather than a big pigmented lesion. And so that urgency is diminished a little bit. The tumor is not there. And I tell them that if we find some cells in the lymph node, that ship sailed a while ago, right? This is reflective of a process that's been ongoing for probably months, sometimes even years. And so, you know, while it's stressful, making sure that we get the plan together and do it in a way that's, you know, optimal for the patient. And there are other times that we take a little longer when we involve plastic surgery. And there's another time where that delay can be anxiety provoking. But again, I try to, so weeks, not months. I think that the biology is not going to change. But then my counter to that, which on a patient level is, but I can appreciate your anxiety. And so I'm eager to get you in as soon as possible. But the biology is not going to change in that period of time.
Great, thank you. One of the questions from our viewers asked, are the recommendations that were discussed today different based on the type of melanoma, cutaneous versus acral versus nodular? Can you give some clarity there based on if some of the standards and the recommendations that you expressed would differ or change based on the type of melanoma?
I can start, and I'm sure Dr. Boland will have thoughts on that too. So if I have a patient with nodular melanoma, so let's say that I get very lucky and find a thin nodular melanoma, and maybe it's only 0.6 millimeters. When I find it, I'm going to, but maybe it has like a high mitotic rate. I know that melanoma has a higher propensity for behaving badly. I will get my oncologist involved earlier. Acral melanomas can be also more aggressive. They're also, and both those subtypes are more likely to be found when they're thick, that just because they grow more rapidly. I also know that, for example, if I have something on the nail or on the hand, that we as a team may want to call in one of our plastic surgery colleagues who specializes in hand surgery, let's say, so that resection is going to be harder. So I am more concerned and more vigilant about nodular or acral melanoma. I have a lower threshold to call in reinforcements, and I'll let Dr. Boland talk about how that might influence her sentinel node decision.
Yeah, I think it certainly doesn't really impact the decision regarding sentinel node, but I would say that those types of melanomas may often be understaged also, particularly the acrals. I see people come in with a 0.2 millimeter melanoma and a big goomba, like that clearly has not been appropriately. It's not that the biopsy wasn't appropriate, it just understaged what was actually there. And so those are patients in whom I would have a conversation about, particularly the acrals, where it's hard to get a good biopsy of the entire specimen, that maybe, we either do a staged excision, meaning we do a 1 centimeter, but don't close it, and make sure that we really know what we're dealing with, and we can take an additional centimeter, once we get the final pathology. And so those are times where, or in certain places where it's on the cusp of 1 to 2, but I think it's probably actually understaged by the biopsy, I would tend to go ahead and take the wider margin. But the acrals factor into, I think, just often being understaged. And then we didn't talk about mucosal melanomas that is managed by different members of the team. So they don't always come through the cutaneous pathways. Sometimes we see them, but the guidelines for those are a little less well-defined.
Wonderful. Well, thank you both. There have been quite a few questions, comments about different types of testing. So I'm kind of going to give you the gamut, and we can address them as you see fit. So one question was about 3D Doppler imaging and how this has been used internationally to find metastasis that might be missed by an initial biopsy. There is also a question about patches. So there are companies now that have patches that you apply to the lesion, and then it's sent away to find potential cells that are misbehaving that could be a melanoma. And then there is the question of getting your tumor tested, right? So this looking at the genes and the expression in the tumor. So kind of different testing modalities. And I know we could have probably 3 more webinars on all these topics, but I wanted to sort of give you a sampling of the questions some of the viewers are asking if you want to comment on, again, those three different quote unquote testing modalities.
Dr. Ferris, I'll let you talk about the tapes. I'm happy to take on the ultrasound question in whatever order, if you think that's a good.
Sounds good. Yeah, you want to start with ultrasound and I'll move on.
Sure. I'm not certain that I'm exactly sure what the question is asking. In our practice, and I am not familiar with a lot of use of nodal ultrasound for the primary site, meaning we don't use nodal ultrasounds to assess the site of a wide local excision for a subsequent local recurrence in that vicinity. There is well-established use of nodal ultrasound, so ultrasounds of the regional lymph node basin. And actually our practice changed after a trial that I didn't mention here because we weren't getting into that, but MSLT2, which showed that if you have a positive sentinel node before 2017, if you had a positive sentinel node, we would go back and remove all the lymph nodes in that basin. And that's a much bigger surgery. It's much more morbid. And we found in that trial, you could actually monitor the lymph nodes with nodal ultrasounds every 4 months. And if you saw progression in the nodal basin, you could offer surgery to that patient and it wouldn't affect recurrence elsewhere. So it is a very powerful tool. And I think that really operationalized the use of nodal ultrasounds more broadly. I think many institutions were using them for nodal assessments on an anecdotal basis, or not necessarily in replacement of cross-sectional imaging or CT or PET scans. But I think that really made it much more broadly used. And I will say that in that question you asked earlier, are there patients who don't get a sentinel node? And this is a very long conversation of patients who decide to leave the algorithm. We do sometimes use nodal ultrasounds to monitor them. So that certainly is in practice, and I would say is in much more common practice since MSLT2.
I can tackle the patches. So this is so what this is referring to is this something called a pigmented lesion assay, which is a patch, or really it's like a piece of tape that can be put over a mole and removed. So this is basically something that you would do if you have or that I would do as a dermatologist. If a patient came in, they had a mole or a lesion on their skin, I wasn't sure if it was melanoma. So if I know it's benign, I'm just going to say, let's leave it alone. If I know it's melanoma, I'm going to take it off that day to get, a full diagnosis. But if there's a lot of, gray area where it looks atypical, I'm not sure. One option I can give to the patient is this piece of tape. So the tape goes over the skin, it's removed, it's sent out to a lab, and they're looking for the expression or mutations in 3 different genes. And those help to predict how likely it is that that lesion is a melanoma. So if none of the genes are expressed or changed, we say it's a very low likelihood. There's a, less than 1% chance that's a melanoma. If all 3 are there, there's about a 70% chance. So it gives us some information. When do we use this? I think it's a good tool in certain circumstances. Some patients, much like some, really don't want to get a sentinel node biopsy. Some really don't want a skin biopsy, maybe because they have been getting 10 a year and they're tired of it. Maybe it's in a very cosmetically sensitive area like the chest. Sometimes it's right in the middle of the cheek and they don't want to have that done. So it can give information. It doesn't give you a diagnosis. It just gives you an idea of if how high of a probability it is that that's melanoma. So you might say, well, if none of the genes are present, I'd rather just watch this. And if it changes, then get a biopsy. But, if 1 or more genes are present, then I would go ahead and take that scar on my face or my chest to not miss the melanoma.
Great. And then the one thing that we still need to touch on is, hearing about getting your tumor tested for genetic mutations. Maybe Dr. Bowen, you could speak to this a little bit, or Dr. Ferris. I'm sure you both have thoughts on it, but a lot of times people will say, I'm getting my biopsy analyzed or tested, or they're looking at the characteristics of my biopsy before next steps. Can you talk a little bit about what that is?
Sure, and I think Dr. Ferris will probably also have some nice contributions here. I think that our last speaker did a really great job of delineating this idea of germline mutations, these hereditary mutations that are passed on in your family that are propensities to cancer syndromes, potentially if they're occurring in the germline, versus an acquired mutation. It's just bad luck. You acquired a mutation and it formed a melanoma, and your melanoma has specific mutations that are unique to your melanoma. We know that in certain patients, about 50% of patients have a BRAF mutation. This is a driver mutation in melanoma. And in more advanced disease, we do that genetic testing to get information that actually can guide treatment decisions, not for our early melanoma patients that we're talking about today. In fact, we don't get that testing for them because it doesn't impact how we treat them. But in patients who do have positive nodes or who go on to the more complex melanoma algorithm, we always get some type of genetic testing of the tumor to offer us not just information about how they're going to do, more importantly, for treatment decision making. And now, sort of dovetailing into that, there are a whole host of gene expression panels that are being done on the primary tumor. And this is a space to try to guide, offer beyond what we described, Dr. Ferris described, you know, these characteristics, depth of invasion, ulceration, mitoses, the features we've been using to try to inform clinical decision making. But I think that's a really exciting emerging area. Right now, they haven't, at least in our practice, haven't been incorporated routinely into clinical practice, but I think we're all eager to add more layers of biology to the clinical decision making.
Yeah, I don't have a lot to add. I think you're right. I mean, you know, one of the things we're always taught in medical school is only order a test if you know what you're going to do with the results. So if the results are, I'm going to put you on this medication instead of this one, by all means, that's a useful test. But just knowing the genetics of your melanoma doesn't really give you information. You want to know how you're going to use it. And you know, one of the things is, you know, it's generally recommended if you're going to test for that reason, let's say that there's melanoma that's spread to the liver, it's actually ideal if you have a piece of the liver melanoma to do the testing on that so that you know that your metastatic disease is going to, you know, when that's feasible, is going to respond. So yeah, it's not sort of a given that everybody's melanoma should get genetic testing.
Great. And we have time for about one more question. And this is kind of an interesting one. We talked earlier about melanoma in situ and how it's common. And one of the questions was asking about having melanoma in situ on one side of the body, and if that's common or not. Is that something you see, Dr. Ferris, in clinic?
You know, we do, and there are studies that show that skin cancers are a little more common on the left side of the body, and that's in the United States. And we think that that's actually because of the sun exposure while driving. So, you know, you probably aren't, I'm probably not good at thinking about sunscreen when I jump in the car, but if you have somebody who is on the road a lot driving, you know, you can get UV exposure through windows and certainly with the window down. So that can happen. I have seen weird things where patients have had all their melanomas on half of their body, or, you know, their mother also had melanoma on their left arm and they got it on their left arm. It's hard to know how much is genetic, how much is chance. But we do think at least that the sun exposure, particularly on the face, can make a difference. I don't know if you have any other thoughts on that, Dr. Boland.
I think you did that was exactly, I totally agree. I mean, it probably, there are some contextual reasons, you know, relating probably to sun exposure. Who knows what the person did, or how they drive, or what their patterns are. But well, yes, we see all kinds of unusual patterns, but I think it's probably exposure related.
Great. Well, with that, I think that's a wonderful plug for Melanoma Awareness Month and wearing sunscreen and protecting yourself and avoiding peak hours of the sun and seeking shade. And again, lots of great resources at melanoma.org. I want to thank everyone for their participation, our wonderful panelists, Dr. Ferris, Dr. Boland, and Dr. Nelson. And again, I want to thank Castle Biosciences for their very generous support of our Ask the Experts series. And with that, I want to let everyone know that this session will be available on demand. So if you joined a few minutes late, or you want to share it with your friends and family, it will be available via our website, melanoma.org. And we will be hosting many upcoming Ask the Experts series with topics. And if you have a topic suggestion or something you're interested in, please submit that to us at education@melanoma.org. But again, thank you to both of you, and certainly Dr. Nelson for recording her session, and wishing you all a wonderful evening. Thanks so much.
Thank you. This is great.
Thank you.
Thank you.